All right. So any questions from last time? Talking about renal disease, talking about how we can treat drug-induced kidney injury or prevent it, because obviously prevention is more important than treatment in regards to helping to preserve people's kidney function, right? Any questions on that? You guys know a little bit more about dialysis. Have you guys covered any urology stuff yet? Like erectile dysfunction, BPH, fantastic. All right, so we're going to cover that today. This will be our last section, and then you'll have your test next week, and you'll be finished. You'll be done with Farm 1, and then Farm 2. So, more to come. That's okay. I'll be out for the first few weeks due to my second baby being born. Thank you. Hasn't happened yet, so I'll wait for the congratulations. Yeah, almost congratulations. It's most likely going to happen, but we'll see. I imagine it's going to go fine. And then I think Dr. Hendricks will take over for the first few lectures. I think someone else is about to be a daddy, so Hemonc will get moved towards the front of the line, from what I've heard. That was just now. So anyway, we're talking about rearranging the medicine course a little bit. So she'll probably give you my lectures on Hemonc stuff, and then I'll come back in late January, and we'll continue out for the rest of the semester. That's probably how it'll go for as far as I know for right now. Okay. So anywho, let's talk about erectile dysfunction. Something that never gets any less awkward to talk about, no matter how many times I do it. But how do we define it? Basically, it's the inability to achieve or maintain sufficient erection for intercourse, right? So typically, like 3 months or more is considered to kind of be, the actual definition where you can get actually diagnosed with it, and is different from like decreased libido, ejaculatory disorders, or infertility. So this is a very specific issue with actually achieving and maintaining the erection versus anything else, right? Do you know anything like drug-induced reasons why you may have, like, say, decreased libido or any issues with libido? Hmm? Okay. There's a lot of psych meds. We'll talk about that next semester, but there's a lot of psychiatric medications. So you think about things like alcohol. Alcohol is a CNS depressant, right? People who get very, very CNS depressed, they eventually pass out. Very hard to achieve an erection when you're passed out, right? So it's one of those things where benzodiazepines and other drugs that work like alcohol can also cause that, right? So this is a separate issue than what you would see with these medications, what they're going to treat specifically. A lot of antidepressants can affect this, right? So again, you're depressed for several reasons, you're on a medication, and all of a sudden you can't have sex. That could be further worsening the depression. It's always something to consider, and we'll talk about other drug-induced causes for that and ways to treat that. But this is, again, specifically referring back to how we can affect blood flow and actual the physical manifestations thereof. So anywho, typically you see pretty low incidence of this occurring in younger men, typically as they get older. What kind of happens when guys get older? Testosterone does what? Typically goes down. Yeah, so testosterone production is going to go down. That's going to be important. What else kind of happens as people get older? They do wrinkle. Yes, that is true. I cannot dispute that fact. Blood flow differs, right? So you can have sclerosing of the veins, you can have issues with blood flow, and that can be very important. Also, think about when patients get very old, they start to have dementia, they start to have Alzheimer's, things like that. That's also another reason why, due to mental decline, they could also have impotence due to that, right? So again, there's also a neurologic component. So if you ever have patients who have like a spinal cord injury, that could be another reason why as well, because the brain can't really signal down to say, hey, it's time to go. Then that's not going to work either, right? So that can be lots of different reasons why this could occur. Now, there's lots of other concurrent conditions that can help to speed this up, so like diabetes. We know that has really negative effects on blood flow, especially in places like the kidneys and the peripheral, especially in the extremities, especially as far as like nerve conduction goes. They have like neuropathies that develop. A lot of that has to do with this kind of damage from the extra glucose. The same thing can happen here, so you can see impotence develop from that. And I mentioned psychiatric disorders, medications, etc. So the biggest thing to note here is that as far as from the physiology standpoint, typically you have these two corpus cavernosum, kind of see them being laid out here. Typically you're going to find that during a normal kind of resting state, you're going to have pretty balanced flow between the venous and the arterial side, right? So again, nothing's really being impeded here. Typically what you're going to find when you have someone in an erection, you're going to have an increased arterial flow, so more blood coming in, and then on the venous side, you're going to be decreasing flow out. So basically just more blood going in than coming out, and that's where you get the erection from. So again, a lot of our medications are going to be focused on helping to achieve this for patients who can't do so otherwise. So this is important to know some of the secondary mediators that are involved here, because this is how a lot of our medications are going to work. And so we'll see that as far as the arterial flow, this can be enhanced by things like acetylcholine. We know acetylcholine is very important as far as the autonomic nervous system goes, very important for skeletal muscle activation, things like that. But this acetylcholine mediated vasodilation occurs here through things like cyclic guanosine monophosphate, CGMP. You guys remember when we talked about drugs that donated nitric oxide, like nitroglycerin? What did that do to the vessels? It dilated them, right? Because by donating nitric oxide, you increase the amount of cyclic GMP that gets made. Same thing happening here. We're causing arterial dilation. It's going to help to increase blood flow to the penis here. So again, increase in cyclic GMP. You also have this vasoactive intestinal polypeptide, but CGMP is the big one we're going to focus on for our medications for this lecture. Okay, nitric oxide I mentioned here. And then also you're going to notice there's prostaglandins. Prostaglandin E specifically is going to help to enhance cyclic AMP. So more cyclic AMP means you're going to have more of that vasodilation on the arterial side. And so we're going to see that a lot of our medications are either going to be focusing on that cyclic GMP standpoint, on that pathway, and then we'll find a few lesser used medications that are going to focus more on the prostaglandin side. So you kind of keep that in the back of your mind. So usually you need that psychogenic stimuli. There's kind of the sacral nerve reflex arc that occurs here, and that's why you might imagine a patient who's had like spinal cord trauma, they may not be able to have this reflex arc intact. So again, impotence can be a very common issue for a lot of the spinal cord injury patients. Also, when you notice a lot of the kind of central stuff going on here, you need things like dopamine. Dopamine is going to have a pro-erectogenic effect here in the CNS. If I have a bunch of medications that are blocking dopamine, as in if you have patients with schizophrenia and we're giving them antipsychotics that block dopamine, you might imagine this could be a drug-induced cause of impotence, right? And then also by looking at things like alpha-2 stimulation, this actually inhibits erection. Do you remember any drugs that worked on alpha-2 receptors of use for hypertension? Kind of worked in the brain. We call them sympatholytic. They decrease blood pressure and heart rate. Or clonidine. Right, remember clonidine? That's it's a pretty common one we use for hypertension. By decreasing that outflow of things like norepinephrine, like that also cause impotence. So you're kind of starting to notice here by giving antihypertensives, this is the major class that can interact with these that can cause impotence potentially, right? So if I give something like clonidine that can suppress that effect, they can see the impotence could be a common side effect, right? So lots of medications can be causing these issues here. And why it's important, you want to make sure that if a patient's coming up complaining of impotence, make sure look at the medication list, look to see what's changed recently, look to see what any kind of temporal relationship there is. Maybe switch them off to a different medication. That way you don't have to actually treat them for the erectile dysfunction. You can just do it by switching a different med for their hypertension or whatever it happens to be. There are, for the detumescence, right, so it's kind of the reverse effect where you're starting to balance out that blood flow again. To go back to a more kind of resting flaccid state, you're going to have this contraction of the vascular smooth muscle, and this is going to be the decrease of arterial flow, and then you're going to see venous outflow will start to increase. And that's going to be mediated through norepinephrine. Okay. Anyway, so testosterone, there's a lot of hormonal effects here. Testosterone is going to be important. You guys remember any hormones are more potent than testosterone that your body produces? It's ever heard of DHT, or dihydrotestosterone? Yeah, it's an important hormone because testosterone, while itself has androgenic properties, it gets converted into DHT, which is actually more potent, it's more androgenic. And so that'll be important when we talk about some medications that affect this 5-alpha reductase enzyme. Basically, that enzyme, 5-alpha reductase, will convert testosterone over to DHT. And so this will be important when we talk about things like BPH, or benign prostatic hyperplasia, because having more DHT around, well, it can help with things like muscle growth and blood counts and things like that. You'll also end up seeing that it'll also increase growth of the prostate, which can lead to some issues, as we'll see a little bit later on. I'll have a small amount of it being converted to estradiol. So again, when we cover stuff in the endocrine section, we'll probably talk about this again, but there's a lot of interplay between the different hormones, and that things like testosterone can be converted to estradiol, progesterone can be converted into all sorts of other things. So there's a lot of interplay here. As you might imagine, someone who's kind of has too much testosterone activity could see some increased estradiol, and then gynecomastia form from that, right? You guys remember any other medications that can cause gynecomastia we talked about? Yeah, spironolactone, right? Because that was actually an androgen receptor partial agonist. So that was actually only kind of partially activating those testosterone receptors. And so those guys were actually getting kind of a relative decrease in their testosterone activity, right? So again, I'll kind of think about how it all kind of loops together. And so for these patients, you want to make sure you're kind of carefully interpreting these levels. I'm not going to get super into detail with this, but you may find that levels may be normal with guys who are experiencing erectile dysfunction. They may be abnormal. It doesn't really give you the full picture. And also, if you have decreased testosterone activity, guess what? You're also going to have decreased libido. So you have to kind of decide, which is the major component here. How's testosterone kind of interplaying? And again, you'll cover that in other classes, so I'm not going to belabor this point. But as far as other causes for impotence, you can see things like vascular damage being done due to peripheral vascular disease, arteriosclerosis. I mentioned the neurologic conditions like stroke, spinal cord injury, and certainly hormonal effects here as well. Because again, a lot of the testosterone is produced where? Not the testosterone specific. You have like FH and LSH that gets produced there, but then that goes and stimulates the testicles, right? So the testicles where a lot of the testosterone is made. If I were to cut those out due to cancer or some other reason, thus you can see you'd have a relative decrease in testosterone, right? So again, these are all important things to consider. Look at the full history to find out kind of what else is going on for these patients. Anyway, and then psychogenic erectile dysfunction, a lot of that goes back to things like depression, mental, CNS depressants, things like that can be affecting the actual mindset of the patient, making them kind of not really in a mental state in order to achieve an erection. A lot of times it's going to be multifactorial, so there's multiple things you can kind of hone in on and try to figure out. Again, make sure the patient's in a proper mental frame of mind, as I mentioned. So sometimes they can have performance anxiety, Alzheimer's disease, lots of different things that can affect this. Hypothyroidism, as you might imagine, hypothyroidism. What does that patient kind of look like? Like up and peppy and moving around. They're kind of slow and sluggish, and guess what? They probably don't want to have sex either, right? So that's another thing to consider. Mental disorders, all kinds of different factors that can play a role in this, just from the mental standpoint, in which these medications aren't really going to be as useful as it would be if you can kind of correct this mental health issue. So anyway, a lot of medications can cause erectile dysfunctions. We have anticholinergics, so things like antihistamines. We've already talked about several of those. I've seen things like diphenhydramine, doxylamine. Those can have antimuscarinic activity, which can affect the blood flow and cause issues there. Some of these are going to be anti-Parkinsonian drugs. We'll talk about that, along with a lot of our psych meds like phenothiazines and TCAs next semester, so don't get too hung up on that. And then you'll just note that there's also a lot of psych meds that are going to be causing this. So tricyclic antidepressants is what when I mean say TCA. We'll talk about all those later on. And bupropion. Anyone ever heard of Wellbutrin? You remember what else we used bupropion for? For smoking cessation, right? So this is actually a really good medication to use if you ever have a patient who has depression and they were on, say, Celexa, or they're on Zoloft or Paxil, whatever it happens to be, and they're having erectile dysfunction issues. Like, this is actually a great drug you can switch them over to, is bupropion, because it doesn't really affect the sex drive quite so much as those other drugs. But anyway, I digress. And again, dopamine antagonists are going to be a big thing here. So a lot of these are psych meds. We'll cover those in next semester. So anyway. So other things you can see, for patients are on estrogens, that can affect this. Anti-androgens, right? So I mentioned spironolactone kind of having those kind of pro-estrogenic kind of effects by only kind of partially activating androgen receptors. Spironolactone, obviously mentioned. Even some things you might not consider, like cimetidine, ketoconazole. Sometimes these actually work to inhibit the breakdown of hormones like estradiol, and it can actually lead to increased kind of estrogen activity, which can lead to impotence. And then I mentioned CNS depressants as well. Again, if you're kind of suppressing that suppression, or suppressing the perception of psychogenic stimuli, they're not going to be able to respond appropriately. So if they're passed out on the floor, they're probably not going to be able to respond really to anything at that point, right? So anyway, other things that can affect the actual blood flow is going to be a lot of antihypertensives. So this is a big side effect from a lot of these things like diuretics, right? So decreased intravascular volume. Obviously, body's got priorities and where it wants to send blood to. Genitalia are not one of them, unfortunately, right? So the brain and the heart are going to be the big priorities there. So diuretics can cause that. Beta antagonists, mentioned that clonidine, another drug called methyl-dopa. We'll talk about that when we get to the kind of the women's health section. We use that for eclampsia sometimes in some women. You're going to see these less frequently with ACE inhibitors, ARBs, and also calcium channel blockers. So this is actually one of those things where if the patient is having issues, they're on, say, metoprolol, and they're having issues with impotence, you could actually try switching them over to something like an ACE inhibitor, and they wouldn't really have so much of those issues, because, again, that arterial blood flow is not really being affected quite so much. Does that make sense? Right. So kind of think about the mechanism of the drug and how it's going to be affecting different areas of the body there. We'll talk about some other drugs here, things like finasteride and dutasteride. This will be important when we're talking about 5-alpha reductase inhibitors later on for BPH. We can kind of keep those in the back of your mind. But even drugs like lithium carbonate, which anyone know what we use lithium for? Bipolar disorder, yeah. So if you have like bipolar disorder, we would use that. And even know what soda lithium used to be in? Lithium actually used to be included in a soda. Like, remember how like cocaine was originally Coca-Cola? It's actually 7-Up. It's actually 7-Up actually had lithium in there for a while, so it definitely made you feel better, but also a lot of toxicity associated with it. Well, no cocaine in it, unfortunately, anymore. So, anywho, but again, other miscellaneous drugs. So again, always run those interactions just to see like, okay, is there a medication that could be causing this potentially? Because again, you don't want to just add on medication after medication to treat these side effects. Obviously, do a thorough history, look at the medication list, concomitant disease states, and then you can also look at testosterone levels. Obviously, if it's in the tank, they're having issues with libido and with impotence, like, obviously you can kind of take that to be like, well, this is a probably likely a reason, but you can kind of take it in the holistic kind of picture. So anyway, our treatment, what we want to focus on here is we want to improve the quality and quantity of suitable erection for the patient. Make sure they have reasonable expectations. These drugs are not going to be silver bullets by any means. They need to have reasonable expectations. And you want patients only with legitimate complaints. Does anyone know where we keep drugs like sildenafil or Viagra in the hospital? Do we just like keep it like just out on the shelf in the pharmacy? We actually keep it locked up with a lot of the narcotics. Anyone know why? Why is it sought after? Okay, but they don't have erectile dysfunction. Why would they want to steal it? Yeah, so recreational abuse is one of the things I always consider. This is why you actually have to like keep it locked up. And so you might think like, well, Dr. Wood, why do you have it at Nemours? Why would you ever use it for children? And I'll give it to little girls because actually one of the things we'll see with these drugs is they can actually affect pulmonary blood flow. You actually use it for a lot of our cardiac kids. So if you ever see like a little girl who's taking Viagra, there's probably a pretty good reason for it, other than simply maybe her dad's stealing it for recreational purposes. But again, that's one of those things you have to consider. Like it's kind of a lifestyle kind of medication. People steal it, and so we have to keep it locked up like a lot of these other drugs. So, oh yeah. Mm-hmm. Mm-hmm. Yeah. So you might have had a legitimate use for it. And again, the other thing is like hospitalized medication. We'll talk about those in just a second. Yeah, so let me get in the mechanism. We'll kind of go run back around to that. So we'll see why it's effective for that. Anyway, we want to make sure it's well tolerated and also talk about reasonable costs. These drugs, depending if they're on brand or not, used to be very, very expensive. It's one of those things where like patients only buy like, I'd get patients who get a whole script for like, 30 pills. And they come to fill and they would be like, I only want one. Usually on a Friday night. Usually they're like kind of dressed to the nines. I said, okay, here's the cash price for one. Anywho, we want to make sure we're correcting underlying disease states to look at if they have hypertension. Hypertension, obviously, we know can kind of expedite some of this vascular damage that occurs. We like to correct this if we can. Coronary artery disease, dyslipidemia, all these other things, smoking, alcoholism. Let's try to fix this first. If it's more of a psychogenic kind of issue, like look at psychotherapy, like look at cognitive behavioral therapy to try to fix those issues. If they have depression and then they can't have sex because they're depressed and then they get more depressed because of it, like that's kind of a sick cycle that needs to be corrected other than with just medication. They probably need to talk to somebody about that sort of thing. We'll talk about vacuum erection devices very, very briefly because it's certainly not my realm of expertise. We'll talk a lot about pharmacological therapies and then a few surgical options for these patients. So the ideal treatment for this is going to be something that has a very fast onset, something that's efficacious, convenient, discreet also should be on here as well, and I'll talk about why that is in a second. Cost effective, limited side effects should be common there, and then limited drug interactions. So these are all things we would like to have ideally. Not all of these therapies are going to offer all of these issues here, right? Generally, you want to go from least invasive to most invasive. Some of these, obviously, you don't want to go to surgery if you don't need to, but we'll look at some options for that a little bit later. Anyway, so again, looking at kind of a treatment algorithm, you have a patient with erectile dysfunction, you've made the diagnosis, you want to make sure you remove any kind of risk factors. If the patient is has hypogonadism, they have a low testosterone levels, you can correct that first. That can be one of the easiest things you can kind of fix for the patient. We'll cover that more in a different section. We talk about more in the endocrine section next semester. But again, remove risk factors, remove any medications that could be interacting here, and try to treat any of those kind of underlying diseases. First off, we're going to talk about our phosphodiesterase inhibitors. These are going to be where our Viagras and Cialises and Levitra are going to fall into. We'll talk about those being kind of the gold standard therapy nowadays. Obviously, if they're effective, you can just keep on going with them. In some cases, you may find that they're contraindicated, in which case you may need to use some other like devices. We'll talk about devices very briefly. And then we'll also look at some more invasive therapy like intracavernosal or intraurethral alprostadil. Does anyone know how we administer an intracavernosal drug? With a needle. I don't want to do that. No one wants to do that. So let's go oral first, and then we'll go from there if we have to, right? So we'll look at these different options. Then at the end of the day, if nothing else is effective, penile prosthesis, however you say it. It's kind of like, someone described it as like a Barbie doll leg that gets implanted in, so it's flexible. I don't know. Like I said, not my realm of expertise, but it's a thing. Go talk to a urologist. He probably has way more knowledge about it than I do, but again, your mind can run with it. Anywho, so kind of the early treatments that we had for this was like a vacuum erection device. So kind of two components to it. There's a cylinder and there's a pump that cause negative pressure. That negative pressure will cause a lot of blood flow to go into the penis, and then you'd have like constrictive bands and things like that to kind of keep the blood there. Now imagine how conspicuous is this? Pretty conspicuous, right? If you got like, hold on, let me get my pump ready. Not super discreet. So from that standpoint, even though it was pretty effective for a lot of people, people didn't like that. Not very discreet here. But they're great for patients who cannot tolerate medications, right? And we'll look at some very specific patients who are contraindicated. It's very, very important you know those contraindications so you don't accidentally give them one of these drugs and they accidentally, have bottomed out blood pressure and all kinds of other issues that come about from this. So they can also be used in potentially in combination therapy or prior to surgery if the patient is going to be going down that pathway. Again, I'm not going to get super into detail on that. However, what we are going to focus a lot on are phosphodiesterase inhibitors. These are going to be the gold standard, as I mentioned. This is where all of our Viagra, Cialis, Levitra are going to fall into play here. Basically, what we're going to see here is that normally, the normal course of things, as we talked about, is you'll have a sexual stimulation of a patient. They will release nitric oxide from these nerves and sacral complex and also into the endothelial cells. That is going to cause nitric oxide to release or to stimulate production of guanylate cyclase. Guanylate cyclase, very similar to adenylate cyclase, is going to generate CGMP, right? CGMP is going to cause vasodilation of those arteries, and then you're going to cause increased blood flow into the area, producing an erection. Now, how does cyclic GMP get broken down? You guys remember we talked about any medications that can affect that, like CHF. We talked about milrinone and enamrinone, right? Those are drugs we can use sometimes for CHF. Those are actually phosphodiesterase inhibitors that actually cause vasodilation, but they also can increase the amount of cyclic AMP in the heart and actually cause increased contractility. So if you had a patient with a CHF exacerbation or coming in, their EF is especially low, more so than their normal, you could give them this drug that would inhibit the breakdown of cyclic AMP, would increase contractility, increase ejection fraction. Those are great, but the thing to note is that you can't use those drugs for erectile dysfunction, and the reason for that is there's different varieties of phosphodiesterase. Very similar to how there's different varieties of serotonin receptors, as we've kind of already seen with like the GI section. There's different types of phosphodiesterase. There's different subtypes. We'll talk about those in a second, and those are important to understand as far as side effects go. Certain of these drugs, phosphodiesterase inhibitors, will have different side effect profiles depending on which ones they're actually specific for, and we'll look at that more in detail in a second. But basically, by inhibiting breakdown of cyclic GMP, you're going to have more activity of it, thus you're going to have more of a sustained sort of erection for the patient, right? Notice they still have to have that psychologic stimuli, right? They still have to have that input to saying, hey, it's time for sex, but this will help to kind of keep that cyclic GMP being formed around for longer. And so like one of the kind of misnomers people may, if they're not familiar with the drugs, may think about is that once you take it, you just have like an erection like until that drug is gone. Not actually the case. You still need that psychogenic kind of stimuli right there, right? So if you had a patient who was too drunk or they're on CNS depressants and they could not respond to that normally because they're passed out, the drugs really wouldn't have too much of an effect there, right? So you still have to have that stimulus, that nitric oxide stimulus, in order for the drug to be effective. Kind of make sense? All right. So anyway, the big ones we have here, we have sildenafil, vardenafil. Sildenafil, Viagra, kind of being the first one that kind of got a lot of notoriety. Vardenafil, Levitra, tadalafil or Cialis, and then avanafil or Stendra. This is probably the newest one that's out there. Again, these are going to be analogs of cyclic GMP that actually will, they're non-hydrolyzable by phosphodiesterase. So by basically being kind of these false cyclic GMPs are going to get preferentially interacted with by the enzyme, prevent the breakdown of real cyclic GMP. And notice it's going to be, the big one we're going to be focusing on is PDE5. That's the primary one that's going to be responsible for causing increased penile blood flow, right? when we were looking at the anaminone and milrinone that we were using for CHF, that was actually PDE3. So if you're thinking kind of like the vasculature as far as like blood flow coming out from the heart goes, think PDE3. For penile blood flow, think PDE5. Also for the lungs, think PDE5 as well, as we'll see here in just a second. The reason, though, that we see a lot of side effects is because these are not super specific for PDE5. There's a little bit of overlap as far as which enzymes they inhibit, and so we'll see some activity, some side effects associated with that. So big things to note from this slide here. Again, don't memorize the whole thing, but we'll get into more detail as we go into these individually. So notice here PDE5, that's kind of the primary phosphodiesterase we're concerned with. There's PDE6, which we're going to see is going to have certain side effects, especially ocular side effects. And we never heard of like someone taking Viagra and going blind. That's one of the things I should warn you. If you listen to the commercials, you may hear that. But that's we'll talk about that in a second. PDE11 is going to be found mostly in the muscle. And so we'll talk about that and some of the side effects associated with it. So notice things like, sildenafil has a lot of PDE6 activity. On the other hand, tadalafil is the only one that really has a lot of PDE11 activity. So again, we'll look at the different side effect profiles based on this and based on their selectivities in just a few minutes. Other things to note, these are all going to be oral medications. The big thing to note here is as far as mean plasma half-life, tadalafil or Cialis actually has the longest half-life here, which is nice because they can actually, patient can take it like on Friday and they're basically set for the weekend essentially. So this is actually one of those things where even though it may have been more expensive when it first came out, it might have been more cost effective. The patient only had to buy one pill rather than having to buy 3 potentially, right? So it's one of those things where the increased duration of action was kind of a big sell for a lot of patients. Other than that, that is going to be the primary things to worry about. Again, onset's going to be about 30 to 45 minutes, so that's why it's important to educate patients. When should they take it? When do you think they should take it? Like right when they're ready to have sex? No, it's not going to work super well. All right, we'll talk about some medications that are going to be much more kind of effective right at the time of intercourse. So this one, they have to take it beforehand, right? So maybe they'll take it with dinner, and then afterwards they can do whatever they're going to do. But the big thing here is like make sure the time frame is right. Otherwise, they're going to be sitting around waiting for 30 minutes, and then all of a sudden, the mood's passed, and it's no good, right? So. Anywho, so this is going to be first-line therapy, especially for younger patients, especially those without a whole lot of cardiac concomitant disorders, as we'll see in just a few minutes. It's very discreet. Just pop a pill and you're done. And then you're going to see that we will select which drug we're using based on the side effects. So adverse effects, onset duration is going to be another big one, as I mentioned with tadalafil, and then the cost of treatment itself. Different insurance companies will cover it to different degrees. Some people will, some insurance companies will have like certain monthly limits on how much they'll cover, because again, this is not a medication you take every single day. It's very much as needed sort of medication, right? I guess depending on their lifestyle, it could be an everyday sort of medication, but again, just patient by patient sort of basis there. And it's pretty effective, anywhere between 50 to 80% reported effectiveness. I've not really heard of any cases of it being really ineffective for a lot of patients. But those who have a lot of comorbid conditions, diabetes, hypertension, hyperlipidemia, they tend to be more the ones that are going to have kind of poor response, a lot of it due to kind of the vascular damage that comes with a lot of those disease states over time. So anyway, now if there is any sort of therapeutic failures, you want to consider things like, food interactions. We mentioned on that previous slide that things like sildenafil and vardenafil, they get better absorption when eaten with fatty foods. So again, if they're eating on an empty stomach, they may not get as good absorption if they were to, say, eat it with, I don't know, say some garlic bread that has a bunch of butter on it, or, mac and cheese or something like that. So again, consider the, fatty food. You can tell that I'm hungry for dinner, obviously, things to eat. Patients should probably try around 5 to 8 doses before they can really say whether it's truly effective or not, and they can titrate up on the dose as needed. So you're going to want to start lower dose and then titrate up to help minimize the side effects. And again, avoid a lot of excess alcohol because, again, it can be a CNS depressant. And of course, these are things that may be concomitantly used pretty frequently. Now, you want to be careful. You want to avoid this in healthy patients who do not have erectile dysfunction, because, again, this is more for recreational abuse for their purposes. But they don't need it, right? And so sickle cell patients as well. Have you guys covered sickle cell at all? What happens in sickle cell? Priapism, why is that? Yeah, it kind of sludges things up a little bit. So you can see priapism being a potential side effect of sickle cell disease anyway. This can potentially worsen that, right? So again, you're getting all this kind of blood cells that are being kind of sludged up, leading to what is priapism? Painful, unrelenting sort of erection, right? So again, sticking around for way too long. That's why they always say if you have an erection for more than 4 hours, call your doctor. because that priapism is a urologic emergency. You can see long-term damage being done to the nerves there if you do not fix that. So that's certainly a concern. But you can also see that with patients with leukemia, because again, they are kind of replicating their blood cells very, very rapidly, which can kind of slow the blood as well. Multiple myeloma and other erectile dysfunction therapies. Typically, you only want to use one drug if at all possible, and not kind of mix and match. Because again, this is just going to increase their risk for priapism. So the other isoenzymes of phosphodiesterase we're going to be looking at is PDE6 are typically found in the rods and cones of the eye. So what you can actually see is that if you inhibit those enzymes, it will affect the rods and cones. You can actually either see blurred vision or cyanopsia. Anyone know what that means? If you had to guess. Yeah, it's actually a bluing of the vision, right? So I mentioned, I remember with digoxin, we said it turns your eye vision a certain color. What was it?
Was it yellow?
Yeah, it's yellow. Xanthopsia, right? So this is cyanopsia. And so you can kind of have a bluing of the vision. Interesting, like, because sildenafil comes as a blue pill anyway. I don't know if that was intentional or not, but that is one side effect you can see. Anytime you're having someone who's on sildenafil, they're having blurred vision, any kind of acute changes in vision, they need to stop taking it immediately and come get checked out, right? Because that could be, in some cases, irreversible damage being done with that medication. So you have to be really careful with that. Sildenafil is probably the worst with this one, and then you're going to find that things like tadalafil tend to be least selective for the PDE6, and you get less side effects there. Other big thing. Oh, yes, ma'am.
Sorry. On the last slide, it says it should be avoided in smoking patients.
So that was that recreational abuse we mentioned, where you have strapping young lads who are a little overzealous, I suppose, and are looking for. Yes, exactly. So yeah. No, these are people who do not have erectile dysfunction who are using it anyway, right? So that's kind of that theft kind of situation we kind of mentioned there, but certainly may see other, if grandpa is on sildenafil and then, his grandson goes and raiding the medicine cabinet or something, who knows? Lots of different situations can arise. Anyway, PDE11 is another isoenzyme that's important because this is actually localized in striated muscle, so skeletal muscle predominantly, and so you can actually see myalgias from this. So this is predominantly going to be with tadalafil. So again, we mentioned tadalafil is nice because it lasts for the whole weekend, but the patient's so sore they feel like they ran a marathon afterwards. It's probably not going to be a good trade-off for them. So again, think about that as far as PDE11 activity goes, myalgias. I mentioned, that you can have slowed onset, especially if some of these are consumed with food. So again, 1 to 2 hours, probably a good time frame to give for most of your patients for to kind of get into the system, kind of have its effects there. And we mentioned tadalafil has the slower onset, but the longer duration of action. So again, 36 hours, you can take it on a Friday. They're usually pretty good through Sunday morning, essentially. So it can be very useful from that standpoint. Now, one thing to note, there is some metabolism by CYP3A4, and that other CYP3A4 inhibitors could affect this, right? So if you had a CYP3A4 inhibitor on board, imagine something like verapamil, that would do what to levels of something like sildenafil? Go up or down? There we go. CYP3A4 inhibitor. Levels will go up, right? Yeah, because you're inhibiting the metabolism. So levels are going to stay up higher. And that's where you can see risk for things like blood pressure drops and hypotension associated with that. So you can watch out for those different interactions. And then sildenafil and tadalafil, if you have someone who had really poor renal dysfunction, that would be someone else you want to watch for renally adjusting those meds. Not super common to run into that, but again, you can also titrate the dose as well. Start at low dose, see how they tolerate it, then you can titrate from there. So adverse effects, a lot of it goes back to the effects that it has on the blood vessels, because again, in general, you're going to find these drugs are going to be causing vasodilation. So as you might imagine, when we talk about migraine in the neurology section next semester, you'll find that having blood vessels dilate in the CNS is the primary cause for things like migraines. And so you can see a lot of headaches associated with that, facial flushing just due to those vessels dilating, dyspepsia, because it can actually cause some relaxing of the lower esophageal sphincter. Right, because again, it's all smooth muscle, just the same as it is on the vasculature as it is on the the esophagus. So you can end up seeing some dyspepsia associated with that, and then nasal congestion, dizziness. So a lot of it all related to the same mechanism there, right? You will see in a lot of patients around an 8 to 10 millimeter mercury drop in systolic blood pressure, which is probably okay for a lot of your patients. Most of the time, they're going to be asymptomatic. However, if they're on multiple other medications to drop their blood pressure, you can see some synergism here. Namely, the big one to watch out for is going to be our nitrates, right? Because again, this is directly affecting that nitrate pathway by inhibiting breakdown of cyclic GMP. So if I'm giving something that increases levels of cyclic GMP, there's a lot of synergism there because you're kind of hitting the cyclic GMP from both ends, both production and from the inhibiting the breakdown. You can see some pretty precipitous drops in blood pressure, right? So this is really important for your cardiac patients, because again, imagine if you are or you have a patient who's an older guy, he has erectile dysfunction, but he also has a bad heart, Imagine he is mid-coitus, he has taken his sildenafil, and all of a sudden he has increased oxygen demand by the heart. All of a sudden he starts to get chest pain. EMTs arrive, what are they going to give him? Nitro, right. This is why they need to ask a question. Have you taken any medications like Viagra or anything like that previously? Because if you give them nitro in addition to one of these medications, you will drop their blood pressure and they will bottom out. Maybe have a syncopal episode. But again, if you decrease blood pressure too much, what does that do to blood flow to the heart? Diminishes it, right? It's going to get even worse, right? So again, this is why it's a very clinically important drug interaction. And in fact, if you have a patient who is prone to need nitroglycerin, probably just avoids medications altogether, right? Kind of a bummer for them, but again, like increased life versus having sex, yeah. So we got some other options. We'll talk about those options in just a few minutes. They're going to be better for your high-risk cardiac patients. Okay, so I mentioned around 2 to 3%. You can see this with sildenafil more specifically due to having a little bit higher activity against PDE6. But look for this photophobia, blurred vision, that kind of loss of blue-green color discrimination. That's that cyanopsy that kind of occurs there. Generally, this can be reversible, but the other big thing to worry about is this non-arteritic anterior ischemic optic neuropathy. This is another kind of unique side effect that can occur. Basically, they will develop this kind of sudden unilateral blindness that may be irreversible potentially, right? So again, a lot of it has to do with drop of blood flow going to the optic nerve that will cause ischemia and cause damage to the nerve, which may or may not be reversible depending on the time frame, how long that happens there. And again, it can occur as far as 6 hours after use, up to they've been using it for years, no problem, all of a sudden it just develops, right? Again, more often going to see this with PDE6 effective drugs like sildenafil. So again, just kind of keep that in mind. I mentioned the myalgias, primarily going to see this with tadalafil doing the PD11 activity. And then another kind of unique thing is vardenafil can cause QTC prolongation, right? So be careful throwing other meds that can cause QTC prolongation because you had too many of those on board, and then you get what? Yeah, you get torsades, right? You guys remember what kind of a normal QTC is? Probably like 440 to 450, or like 0.440 to 0.450. Once you start to get like in the 500 range, 500 above, that's where you start to worry about this sort of concern there. So again, not a problem by itself typically, but if you add on other meds that can do that as well, you can see some issues there, right? And I mentioned the priapism, very, very rare, but you're going to see this more with higher doses, and if you have concomitant use with other erectogenic medications, as we'll talk about here in a few minutes. Now, nitrates I've already alluded to as being the primary drug interaction to worry about. You can see severe hypotension. I've already mentioned that mechanism. So again, use is contraindicated. So if they have a patient who has nitro PRN chest pain, I probably would not give them one of these medications here, right? Otherwise, if they had taken one of those medications, taken a sildenafil or something like that, and all of a sudden they need nitro, that would be one of those things where the EMT should be asking the questions beforehand and probably abstaining from giving it to them, right? It's one of those things where the drop in blood pressure could be potentially more dangerous than kind of that acute chest pain they're having. You can give them other medications for that, morphine or whatnot. And then typically we do not recommend nitrate for 24 hours after a phosphodiesterase inhibitor use, or 48 hours for tadalafil, because again, that one has a longer half-life, in order to make sure that drug washes out, and then all of a sudden, when you give the nitrate, you're not going to have that, again, that big drop in blood pressure, okay? If you did have this happen, you guys ever heard of Trendelenburg position? What is that? Yeah, put them head down, legs up. That's going to help them bring blood flow back to the heart and the head, as we mentioned, where the body likes to send blood, and then give them lots of fluids, because again, they're vasodilating, the intravascular space is empty, so you need to give them fluids to try to tank that back up, essentially. Okay, yes, ma'am. Okay. And I mentioned if you have a concomitant CYP3A4 inhibitor on board, like verapamil, diltiazem, you can just drop the dose of your phosphodiesterase inhibitor and then just titrate up. And again, you're titrating to effect, essentially, and just by seeing how effective it's going to be for your patient. Okay, so other medications we can use. We can also use prostaglandins. I mentioned those are effective for increasing cyclic AMP generation. And so we have something called alprazobil, which is a prostaglandin E1 analog. And so basically this is an intracavernosal injection. Brand names include Caverject and Edex. There's also an intraurethral insert. This is called MUSE, which stands for Medicated Urethral System for Erection. Okay. Basically, again, I mentioned it's stimulating dental cyclase, increases cyclic AMP, which actually will help to decrease intracellular calcium concentration. Because with vascular smooth muscle, calcium causes contraction, just like with skeletal muscle, right? So if you decrease that, you're going to have smooth muscle relaxation, and thus increased blood flow going to the genitalia there. This is not nitric oxide dependent. This is really good for patients who maybe have an impaired nitric oxide pathway, so like diabetes, prostatectomy, things like that, or if they failed phosphodiesterase inhibitor therapy. This is the kind of the next step from there on, right? Again, what's kind of the downsides of using these? They're much more invasive, right? So you'd have to give yourself an injection, or you kind of use this intraurethral administration device, which again sounds just as uncomfortable as I imagine it is. But basically, now you're going to find that intracavernosal tends to be more effective, more efficacious than intraurethral. It's very good bioavailability because again you're injecting it right there. Is going to be preferred over some of the other ones. So these are some other medications they used previously. We didn't like to use things like phentolamine or papaverine, mainly due to the fact that there's too much risk for priapism, so we don't use that anymore. Really, alprazolam is the primary one here. And so you'll find that very small doses can get anywhere between 70 and 90% effective. Very, very effective, but the administration is the problem here. And it's pretty short duration of action, only maybe 12 to 44 minutes. So again, this is something you'd want to use much closer to the time of intercourse rather than something like sildenafil you might use a couple hours beforehand potentially, right? And then you're going to find that tolerance does not appear to develop, which is great. So they can continue using it, continues to be effective kind of as long as they're using it, which is beneficial there. Okay. So again, a lot of reasons why people will not use this therapy or will discontinue is usually due to inconvenience, because again, it takes a lot of prep work in order to get yourself injected this medication. Needle phobia, again, I don't like needles going near me unnecessarily, especially to those particularly sensitive areas, so no thanks. Loss of interest, so especially as they get older, especially if they have like mental decline, they may not really be so concerned with that anymore. And then the cost of therapy can be more expensive as well, right? There's a lot of supplies that go with it as well, because again, what do you think is a potential side effect from these injections? If I'm not using proper technique, infection, right? Yeah, because again, a lot of skin flora is going to be right there on the skin. So if I'm injecting and I'm not using proper, aseptic technique, you can potentially see introduction of skin flora and then infection. So anyway, should only be injected into one cavernosus, so they basically kind of alternate size as you use it. And then again, they're not typically going to work for much longer than say like 45 minutes or so, mainly because it gets quickly metabolized and it has very limited side effects. You don't really see the same blood pressure issues as you do with like a sildenafil or something like that, due to the fact that it only has about a half-life of a minute or so. Basically 5 to 10 minutes before intercourse, you would inject it using a pretty small gauge needle, 27 to 30 gauge needle. Do you guys remember how needle gauges work? I guess I've covered that previously. So which is bigger, a 0 gauge needle or a 27 gauge needle? 0 is a lot bigger, right? So again, as you get bigger in needle gauge size, that's the smaller the needle it is, right? So the 27 to 30 is usually a pretty small needle. If you imagine you're trying to get like big intravenous access, like for someone who's coming in for like a code or something, you're like hitting them with like a 16 or 18 gauge. That's a lot bigger than you see with these. So again, very small needles you're using here. Short, because you don't need to really penetrate too far into the tissue there. And again, aseptic technique is super important. And when I say aseptic technique, what does that mean? Sterile. You want to alcohol off the area first. You want to make sure it's very clean. Wash your hands. Have the patient educated on how to do this, because again, they're going to be administering it themselves in a lot of cases, or caregivers will be administering it. So again, aseptic technique is paramount because you don't want them to get an infection. So local effects, they tend to get better as the patient gets better technique with injecting and kind of used to it over time. But you can see these kind of fibrotic areas, these kind of plaques that will develop in some small percentage of patients. Typically that occurs, you can just stop injecting for that period of time until it kind of resolves on its own essentially. But certainly some local pain associated with it, and then priapism is a risk, probably a little bit higher than you would see with like something like Viagra, but still a risk to be concerned with. You can just educate them. If it's longer than 4 hours, come on into the emergency department or urgent care, wherever it happens to be. Anyone know what we use to fix that? A priapism? Yeah, you can do needle decompression, so you can get the blood out. Right, that's one way to do it. Anyone else know anything else? So we actually use a drug very similar to what we talked about for, we talked about like decongestants, like working on ENT stuff. Remember phenylephrine I mentioned? Phenylephrine is kind of like the wimpy cousin to pseudoephedrine. Like a lot of the products you can get for cough and cold stuff on like the shelves at Walgreens is just like Sudafed PE. That's a crappy one. You don't want that one. You want the one behind the counter, right? Because that's a pseudoephedrine. However, phenylephrine, when administered either IV or in intracavernosally, it's a very potent vasoconstrictor. So that actually helps to constrict that arterial blood flow and will help to diminish the erection there. So again, multiple things we can do, but that's one of the ones. But usually needle decompression is another very common one I've seen used. Anyway, With the intraurethral one, you have to be careful. There could be urethral damage, especially if the technique being administering during administration is very poor. You can potentially see things like stricture and difficulty voiding associated with that. So again, usually intracavernous is probably the more common one they end up getting used, but it depends on the patient. Okay, and I mentioned you can have penile prosthetics that are either malleable, which I mentioned kind of like the Barbie doll leg, or you also have inflatable ones that will, again, I don't know anything much more about it than simply the different types that are out there, but pretty satisfactory in a lot of cases for most patients. And again, these are going to be, kind of further down the line. Once you've kind of failed phosphodiesterase inhibitor activity, once you've failed the prostaglandin, this is usually kind of the course where it's going to go from there. Obviously, much more invasive than using any of the other types of therapies. Infection is usually the most common event you can see with this, usually associated around the time that it's implanted. Okay, so any questions on that? All right, so we're going to do BPH, and then we'll do urinary incontinence, but I'll let you guys go for a 10-minute break. We'll come back and then continue on with this. So any questions on the first half? All right. So I'm going to try to boogie through the rest of this, see if we can get any kind of review done. So anyways, we're talking about BPH, very common benign neoplasm in a lot of guys, nearly ubiquitous in old men. It's just going to be one of those things, kind of like death and taxes. Your prostate is going to get bigger as you get older, unfortunately. In the medical management, we're going to look at a lot of drug therapies associated with it. A lot of cases, if it's asymptomatic, you really don't have to worry about it. You can do a lot of watchful waiting in those cases. But we'll look at alpha-1 antagonists. We've already seen some of these in respects to blood pressure. We'll look at 5-alpha reductase inhibitors, we've kind of alluded to previously, phosphodiesterase inhibitors, anticholinergics, and then finally surgery. Obviously going to be one of the kind of the end goals of treatment. So anyway, we're going to see that half of symptomatic patients typically end up requiring treatment in a lot of cases, and usually end up peaking around 63 to 65 years of age or so. And around 60% of those men that are 60 years or older develop clinical BPH, right? So they're actually symptomatic signs of BPH. What are some signs of that, or some symptoms of BPH? Yeah, so dysuria, reduced kind of flow, kind of inconsistency there. Absolutely. There's a really funny. You guys ever watch Saturday Night Live? Those like kind of fake commercials they have, and they'd one like for BPH medication with guys like trying to water his lawn. It was like a really bad hose, just kind of spurting out everywhere, and it was like, try taking this drug, and all of a sudden it was like flooding the entire lawn. It was very funny. Kind of like that though, as we'll see with some of these medications here. So anyway, so what does the prostate do? Kind of like an appendix, no one really knows. Yeah, so it doesn't make the sperm itself, but it helps provide a lot of the ejaculate material and whatnot, things that help the sperm to work a little bit better to make things like fertility a thing, right? So again, they're going to secrete around 20 to 40% of that volume there, and it also has a lot of antibacterial activity, because actually the prostate is really high in zinc concentrations, which is something I didn't really know before. I was doing these lectures, I was like, that's kind of interesting, kind of antibacterial, which again kind of goes back to, because who are more likely to get UTIs, females or males? There's just another reason why males maybe are less likely to also other anatomic reasons, but this is just another little feather in that cap there. So anyway, you see typically two kind of spurts of growth in the prostate, usually around puberty, because it goes up at puberty. Testosterone, right? So you're going to produce more testosterone, and thus more testosterone goes up. What does it get converted into? Yeah, dihydrotestosterone, DHT. Remember, that's the important one there, because it's even more potent than testosterone is. And then usually a second spurt around 40 years of age, and then continues on. The big thing to note here is kind of three types of tissue. There's the epithelial or glandular tissue. This secretes is going to be producing a lot of the secretions, and this is stimulated by the androgens, right? So if you have high testosterone activity, high DHT activity, you're going to see growth in the epithelial tissue. Okay. You'll have the stromal tissue, which is the smooth muscle tissue. This is what kind of governs how constrictive it is around the urethra. These are going to be embedded with alpha-1 adrenergic receptors, right? Where else do we see alpha-1 adrenergic receptors? The blood vessels, right? If I activate alpha-1 receptors, what does that do? Constrict, right? Same thing here. If I can activate those receptors, it constricts around the urethra. Thus, I'm going to have impaired urine flow, right? And with the capsule, is going to be having some fibers connected tissue. Those also have androgenic. And again, make sure to note the difference between androgenic and then adrenergic, right? Adrenergic is going to be responding to things like epinephrine and norepi. Androgenic responds to things like male hormones like testosterone and DHT, right? So remember to keep those two in mind there. So you can kind of start to see, based on the patient, based on what type of problems they're having, this will dictate what type of therapy you're going to use, right? As we'll see. 15 minutes here. So again, we mentioned that testosterone converted to DHT by this 5-alpha reductase causes things like acne, causes things like kind of male pattern hair growth, have definitely more potent than testosterone, and will induce prostate enlargement. So one of the sets of drugs we're going to use actually will inhibit this enzyme to limit how much DHT we're actually producing, right? You'll find that estrogen is a product of androgen metabolism. This is called an enzyme called aromatase. And when we get to either talking about women's health stuff or we talk about cancer, we'll talk about aromatase inhibitors. Now, those are really important for things like breast cancer and women who are have breast cancer, estrogen receptor sensitive breast cancer. We'll talk about that a little bit later. That's another enzyme that's going to be important there. That actually will help to increase stromal growth. Right? So anyway, so there's kind of two different factors here as far as the physiology or pathophysiology goes. There's the static factors and there's the dynamic factors. And so the static factors, as you might imagine, static doesn't really change very much, very frequently, right? Versus dynamic is probably going to be changing more frequently throughout the day. So static factors, this is usually due to absolute growth of the prostate, right? So this is where the actual enlargement of it will physically block off the bladder neck, and that causes the obstruction. And that enlargement is typically due to androgen stimulation of the epithelial tissue, and then a little bit of estrogen stimulation on the stromal tissue. Okay, so if they're having static factor issues, the prostate's too large, it's going to be an androgen problem. The dynamic factors are going to be more related to the alpha receptors, where again that can constrict and relax based on alpha-1 activity. So again, if you're having a lot of alpha-1 activity, it's going to be more constrictive, maybe a normal size, but it's too constrictive. It'll also cause that issue with outflow of the urine, right? So they can typically be triggered by things like stress, pain, things like that can have big effects on the dynamic factors here. So again, you're going to find that you can have symptoms from static, from dynamic, or both sort of factors here. And again, you're going to find that obstruction with the normal prostate size usually due to dynamic factors. And then sometimes you'll have an enlarged prostate will be causing outflow issues, and plus or minus dynamic factors. So again, it could be multifactorial, it could just be one or the other in a lot of cases. And you're going to find that moderate severe voiding symptoms are going to be directly related to those increasing prostate size. So again, in a lot of cases, it's going to be due to just that increasing size of the prostate, and then we'll see what type of therapy we're going to be focused on with that. So anyway, so one of the things you can find medication-induced causes for BPH if you're replacing testosterone. The more testosterone I give the patient exogenously, guess what? They're going to be producing more DHT, right? This is due to the fact that 5-alpha reductase is acting on that exogenous testosterone, same way it is on the endogenous stuff we're producing anyway. So that can cause issues there. You can have adrenergic agonists, right? So these are things affecting the alpha-1 receptors like pseudoephedrine, ephedrine, or phenylephrine. So if you have a patient who's taking cough and cold medications because they're all stuffy and they're taking some Sudafed, that can worsen their BPH. You might notice some sort of kind of a temporal relationship there with the medication use. The other thing you'll notice is that with anticholinergics, this is going to be more due to factors with the bladder and causing urinary retention. So remember, when we have acetylcholine affecting the muscarinic receptors, remember if you have a lot of activation of the muscarinic receptors, activating that parasympathetic nervous system, you see a lot of secretions, right? You see a lot of lacrimation, you see urination, you see salivation, all that kind of stuff, right? We talked about the dumbbells. You guys remember when we mentioned that briefly? So again, you can go back through that and see all that. But again, muscarinic activity causes secretions. If I have anti-muscarinic activity, guess what? I'm going to dry everything up. And the same thing goes with the bladder, because you're going to cause relaxation of that detrusor muscle. So you're going to cause basically the bladder is going to allow it to get fuller. It's not going to be able to, you're really going to retain more urine than you normally would. And so again, you can see how it can be multifactorial, where this isn't really causing the BPH to be any worse, but it could be playing a role in having a little bit of synergy there if you have kind of multiple issues going on. So anyway, so as far as the symptoms go, we know most of it's going to be more obstructive. I'm not going to go into full details on this, but just know that you can see things like bladder over distension. You can have a lot of urinary dysuria, things like that can occur from this. Usually the flow is going to be pretty erratic and can lead to bladder emptying being pretty poor in a lot of cases. And then you have these irritative symptoms, and these are things that happen kind of later on in disease. And this is normally due to kind of long-standing bladder neck obstruction. A lot of this is due to kind of neurologic damage that happens over time with this being distended. But you can see bladder muscle hypertrophy. You can see that the bladder becomes really hypersensitive and very ineffective. So even small amounts of urine can trigger that someone needs to go to the bathroom, even though the may not have very much urine actually in the bladder itself. And so you can see things like nocturia, you can see bedwetting, you can see urinary frequency and urgency. We want to prevent these symptoms if we can by treating the disease state kind of earlier on if possible. Again, symptoms are not always going to be progressive. Some people will stabilize out. They will not have any progression of disease. Just depends on the patient. But again, we mentioned these lower urinary tract symptoms. These are the neurogenic bladder or the UTIs that can develop secondary to a lot of those long-standing issues that I mentioned previously. So these are things we like to prevent by treating the disease early on. Again, lots of complications, things like recurrent UTIs, bladder stones. Again, I'm not going to get fully into this. Just know, and again, if you had to think about a kidney injury associated with this, how would you classify it? Pre-intrinsic or post-renal? It's to be a post-renal, right? Because again, this is preventing blood flow, urine flow. So you actually can see backflow issues with urine back into the kidneys, right? You can see things like hydronephrosis potentially in really severe cases. So you got to watch out for that. So anyway, so basically you will treat based on symptoms. It's very mild symptoms, very not really symptomatic. You can just kind of do watchful waiting. We'll check it, kind of routinely. For more moderate symptoms, you can see things like erectile dysfunction. If they have erectile dysfunction, concomitantly with BPH, you're going to see our therapy will differ based on if they have, say, a small prostate with low PSA numbers. Anyone know what a PSA is? What is that? Okay, prostate-specific antigen, right? And so again, if you have an enlarged prostate, you should be producing more or less PSA. Probably less PSA, right? Because again, the prostate, you don't have as much tissue to actually release as much, right? So again, if it's a small prostate, typically lower PSA levels. And again, PSA is really important also for diagnosing prostate cancer, right? It's another thing we're going to be following as well. So again, they have a large prostate, increased PSA. We're going to see that therapy is going to differ here. So again, we're going to go into detail on this, but kind of refer back to this slide here so you can kind of see where we might choose one drug versus another for our patients based on their symptomatology, based on concomitant disease states. Okay, so our desired outcomes: reduce these lower urinary tract symptoms, prevent disease complications, obviously reduce that need for surgical intervention is always going to be better for our patients, make sure it's going to be well tolerated and cost effective. So we're going to have several drugs that can work here. So one of which is going to be drugs that will decrease the contraction of that smooth muscle there. So this is going to be prostatic smooth muscle relaxers. These are basically going to be reducing the dynamic factors, right? So these help to blunt that really kind of dynamic effect on those alpha receptors. And so these are going to be drugs that block alpha-1 receptors, right? Very specifically block alpha-1 receptors. Again, they do not decrease prostate size. They only decrease how kind of dynamic it is in contracting and relaxing, right, to the normal course of the day. Other drugs we can use will reduce testosterone stimulatory effects, and these are going to help to reduce the static factors. These will have an effect on prostate size by reducing the size of the prostate, and this is going to be where our 5-alpha reductase inhibitors come into play here. And then finally, we'll have the agents that will relax bladder detrusor muscles. This is where we can actually use antimuscarinics. These are going to be more late-stage medications. They're going to be better for reducing irritable voiding symptoms, right? So again, patients you may be caught later on or have not been well treated for most of their therapy. This is where the antimuscarinics are going to be useful here. So agent selection is dependent on the patient on a case-by-case basis. And again, benefits are only going to last while the patient is taking it. So if they had an issue where they're producing too much DHT, I give them a drug that helps to reduce those levels. The prostate shrinks down. If I take away that drug, what happens? DHT levels spike back up. Guess what? Prostate is going to enlarge again, right? So you need to be wary that a lot of these medications, as long as the prostate is still there, they're probably going to be on these for presumably lifelong, right? Unless you do something else about it. Generally, you're going to find that alpha-1 antagonists are going to be first line for most patients, mainly because they work really quickly and they have fewer side effects. And we'll look at some of those in a few seconds. And then 5-alpha reductase inhibitors, these are going to be preferred for cardiovascular patients or those with really significantly enlarged prostates, right? So again, if it comes in as the size of a basketball, probably it's going to be something where a DHT inhibitor or this 5-alpha reductase inhibitor is going to be needed for this, right? And then in some cases, combination therapy is going to be warranted. Okay. So if you have a patient with erectile dysfunction and BPH, this is actually a good case where phosphodiesterase inhibitors may be a good first-line agent, even though they are on their own less effective than the other ones by themselves. But if it's kind of a concomitant issue, you can potentially use this because again, being a smooth muscle relaxer, this can help to relax in that prostatic that muscle there, very similar to how an alpha-1 blocker would. So again, something to consider if you have a patient with both disease states. And again, patients with mostly irritative symptoms. Again, these are going to be patients that are usually kind of more progressive type patients. These are going to have use for anticholinergics, right? These are typically added on, usually not used by themselves in this sort of case. And these are going to be for patients who do not have kind of a high post-void residual, right? So this basically means that you don't want them to be holding on to a ton of urine kind of at baseline because an anticholinergic is going to do what to that urine volume or the bladder volume? It's only going to go up, right? Because again, you're inhibiting the muscarinic receptors. We know that the muscarinic receptors are really important for causing contraction of the detrusor muscle to cause urine outflow to occur. So, looking at our alpha-1 adrenergic antagonists, we have 3 generations. We had the first ones that aren't very good because they were very good at vasodilating, but they also cause a lot of reflex tachycardia. They cause arrhythmias. We don't like these anymore, so we don't use them. There's second generation agents. These have no alpha-2 antagonism, but basically just were alpha-1 specific. These are the things like we talked about previously with our antihypertensives, like prazosin, doxazosin, terazosin. You guys remember that from the hypertension lectures? Remember how they weren't really good for first-line agents? Because, again, they're very good at dilating the blood vessels, but they cause a lot of reflex tachycardia. Also, another big thing you can see, if you're dilating these blood vessels, what happens when a patient, especially an older male or female, they go from sitting to standing? Orthostatic hypotension, right? The blood vessels can't really respond in order to make sure they have enough blood flow going to the brain. So those are big concerns of that. Nowadays, we have third-generation agents, which are called uroselective, because they actually will target a very specific alpha-1 receptor. This is alpha-1A androgenic receptor. These are ones located specifically in the prostate, and so if you have drugs that only affect those receptors, they're very, very specific for that and really shouldn't have a whole lot of other cardiovascular effects. So these are really good drugs for that purpose. Now, as far as efficacy goes, second and third generation agents are going to be equally effective, but third generation have a lot less side effects. So those are going to be the main ones we're going to focus on here. But also note, these are only going to be for the dynamic effects. They have no effect on prostate size. Okay. So we've already covered these before. You have prazosin, terazosin, doxazosin. I might have mentioned previously alfuzosin. This is uroxetrol. This one probably has a little bit more selectivity than the other ones, but again, still considered a second generation agent. The main thing to watch out for, especially in older patients, is syncope, orthostatic hypotension, dizziness associated with it can be very, very detrimental. It can lead to falls, fractures, all kinds of bad stuff, right? The big thing to note is you want to start at a low dose and titrate up gently over several weeks, especially with an older patient, especially with a lot of concomitant disease states. Be very kind of ginger with this medication and go very, very slowly here, because it will have synergistic effects with other antihypertensives, and you're going to find that you want to use longer acting ones. So something like prazosin, very short duration of action. You have to dose it several times. You see big drops in blood pressure, kind of big peaks and valleys with that one. So that's one we don't like to use too often. Usually alfuzosin is probably one of the few in the second generation ones we'll go to because they're a little bit longer acting. It's only really 1 time a day therapy, which is nice here. Again, alfuzosin has the lowest incident of systemic side effects, so this one is going to be a good one to use for BPH as far as for the dynamic effects. But again, a lot of the other second generations probably avoid for the most part, right? The third generation, this is going to be ones that we're going to see used much more frequently, especially since they went generic. We have things like tamsulosin or Flomax. I'm sure people have seen commercials for Flomax before, right? Yeah. So Flomax is a big one that came around. Again, nice because it is not going to cause a lot of orthostatic hypotension because it's so specific for those alpha-1A receptors, right? Things to note, you want to avoid it in patients with sulfa allergy. So again, it would be one reaction you want to watch out for. And there's another called silodosin or Rapaflo. This one causes a lot of drug interactions, so I actually don't ever see this one being used, but certainly we will use tamsulosin pretty frequently. And actually for some of our urology kids that we have over at Nemours, several of them are on tamsulosin due to some of their just kind of congenital urine flow issues. It can actually help with urinary incontinence for some of those patients. Anyway, again, very little incidence of hypotension associated with this. You may get a little flu-like symptoms, nasal congestion, some anejaculation. Those are rare side effects, but again, these are going to be the best tolerated out of the bunch here. So tamsulosin is probably the good one to go with. Also, uroxetrol probably being a close second there. And then I mentioned phosphodiesterase inhibitors. You can see if you were to add on something like sildenafil plus one of these alpha-1 blockers, you can see some synergistic drops in blood pressure. So you do want to watch out for that. But you're going to see less likely of that occurrence if you were to combine something like tadalafil, which I mentioned has a slow onset and a very long duration of action, with something like tamsulosin, which again is very specific for the prostate. Right, so that would lead to the least number of side effects associated with syncope and orthostatic hypotension. Now, looking at our 5 alpha reductase inhibitors, these will have an effect on size of the prostate because they are directly going to be antagonizing the effects of testosterone there, right? And so basically you have finasteride or Proscar. This is going to affect this type 2 5 alpha reductase. And again, this is the one that's primarily found in the prostate. So again, you don't want to necessarily cause decreases in DHT all over the body, because what could that cause? Maybe some gynecomastia, right? What else? Could do things like decrease sperm production. You can see infertility potentially, right? So you want it to be specific to be affecting the prostate, right? So this is nice because you'll see about 80 to 90% drop of DHT levels in the prostate. Also, imagine effects like on lipids. You can have effects on lots of other things, libido, things like that as DHT levels drop. About 70% drop in the serum, which isn't as severe as it is in the prostate, but can still lead to some side effects, as we'll see. There's also going to be dutasteride or Avodart. This is actually a non-selective inhibitor here, and this actually decreases systemically DHT levels by about 90%. Okay, this is only going to be or better for patients who have a large prostate, and it actually can help to slow down some of that disease progression and some of that long-term damage being done for those lower urinary tract symptoms we mentioned there. And both of them are going to be pretty equally effective there. Now, can you imagine any type of patient you definitely do not want to be handling this drug, or anyone who'd be contraindicated from getting it? It's not children necessarily, but what were they before they were children? They were fetuses, right? Yes, there's actually a thing where we actually do not want female like healthcare givers who are going to be giving the medication or handling it. We actually require that they wear gloves, because this is still considered what we consider like a hazardous medication, because potentially this could really screw up a fetus, right? So if you're affecting hormone production in a fetus, that can be very, very detrimental to them. So this is very teratogenic. Category X would not want it, because again, there's no real good reason for a female patient to be on this. So that's why it gets that Category X designation rather than like a D or something. So this is good for patients who cannot tolerate an alpha-1 receptor antagonist, or it can be used in combination with it too. So you can see like Flomax plus something like Avodart, something like that. And again, they can reduce prostate size pretty significantly. May reduce that prevalence of prostate cancer over time, right? So again, if you have less activity there, less stimulation for the prostate to grow, you may see less incidence of prostate cancer. But the other things to consider, it's not going to be fast acting, right? Because again, it's not going to shrink the size of the prostate immediately. Hormones take time to have effect here, so it's going to be a little while before they're effective. You're also going to see a higher incidence of sexual side effects, right? Because again, you're going to be very much affecting DHT levels throughout the body. So that can affect libido, can affect the ability to achieve an erection, and typically there's going to be second line for sexually active males. If it's an older person, who is not really concerned with having sex anymore, this might be an okay drug for them, depending on their situation, right? So you can use this one long term. It'll help to reduce that prostate size, but the second the drug is gone, prostate size is going to go back up, right? So it'll take a little bit of time, but it will go back up. And then looking at sexual dysfunction, you're going to see a lot of ejaculatory disorders related back to, one, the prostatic secretions being inhibited, and also due to some of the erectile dysfunction, possibly due to effects on the nitric oxide pathway there, and then the decreased libido, as I kind of mentioned. And again, pregnancy Category X, do not want female patients handling these, or female healthcare providers, anyone like that. Let's have gloves on. So that's actually one of the recommendations, or one of the requirements we have, is to make sure they're wearing gloves, just like they would any kind of hazardous drug. They could, chemo drugs and things like that. We want to make sure we use appropriate protection. And then as far as side effects go, again, some GI stuff, but again, gynecomastia, as you might imagine, as we're dropping DHT levels, you're going to see more estrogen activity, and that can lead to gynecomastia. So, as I mentioned with PDE inhibitors, you can use this concurrently in patients with BPH who have erectile dysfunction. It may counteract effects of the alpha-1 antagonists and the 5-alpha reductase inhibitors, but again, basically by preventing that breakdown of cyclic GMP, this helps to relax some of that smooth muscle in the bladder, or in the prostate and the bladder neck itself. So again, they could be utilized first line. Not going to be as effective as either of the other classes of drugs, but could be used potentially. Probably tadalafil has the most studied, has the most studies behind it, mainly due to the long half-life of that drug. So, and then I mentioned anticholinergic agents. We'll talk more about these a little bit later on when in regards to urinary incontinence. Just know that these are going to be more for those kind of later irritative symptoms. These are not going to be first-line agents for these patients, right? Anyway. And I mentioned surgical intervention. Obviously, prostatectomy would be the gold standard here. Just get rid of the whole thing. But obviously, there's some complications associated with that. You can have, urinary complications afterwards. So again, we like to avoid this, and if we can use medications to do so, that's great. But again, this would be kind of the end point of therapy if the drugs were ineffective. Okay. Any questions on that? All right. Let me cover up urinary incontinence real quick. Everyone went to the bathroom already. Obviously, this is going to be related back to involuntary leakage of urine, related to urgency. Certainly you can see increased daytime frequency, nocturia, and then you can see lots of secondary effects from this, things like self-esteem issues, depression, etc. And And so you typically will see peak incidence in women around the time of menopause. So I didn't want to just talk about guy stuff today. I also want to talk about female stuff, right? And so typically you're going to see this in older patients, especially 60 years or older, about 38% incidence in there, prevalence there. And then you can see that in some cases, this chronic urinary incontinence can actually lead to hospitalization or institutionalization of some of these patients. So pretty significant. If we can do anything to kind of help prevent that, help to keep them continent for longer, that's going to be good for them in the long run. So looking at the actual physiology here, so again, obviously the lower urinary tract is comprised of the bladder, urethra, the sphincter, and any kind of surrounding structures. Also, that urothelium is also going to be really important here as well, so we'll see in a second. And then looking at the neurophysiology, that detrusor muscle of the bladder is mainly innervated by those parasympathetic fibers, right? So they're going to be responding primarily to what neurotransmitter? Acetylcholine, right? Yeah, because parasympathetic nervous system think acetylcholine, think muscarinic receptors, right? So if I have stimulation of muscarinic receptors, it's going to cause what to that detrusor muscle? It's going to squeeze down. That's going to force the urine out, right? So it's going to give us that stimulation. Hey, because again, if you think about the there's an internal and external urethral sphincter, and again, which one do we have control over? The external, right? Because we can control when we go to the bathroom. If we didn't have control of that, we would just kind of go whenever, right? Not good for us, right? Typically. So it's one of those things where we can have medications are going to help to kind of fix this. They're going to help to allow the bladder to fill more fully to help us have a little bit better control of this. So again, don't get too hung up on which specific muscarinic receptors are. Just know that it's acetylcholine-based muscarinic receptors we're dealing with primarily. Because that's a lot of medications we're going to use for it. Now, we mentioned that you're going to have the proximal sphincter. This kind of internal sphincter is going to be more involuntary, but that distal sphincter or the external is going to be more voluntary. Maybe some involuntary because, again, you can only hold it back so much before, again, it's going to be overridden by the CNS. But for the most part, it is voluntary. The bladder obviously can accommodate quite a large volume of fluid without increasing pressure just due to that relaxation of the detrusor muscle and whatnot. But again, you're going to see that compliance is going to be accompanied by a smooth muscle relaxation. So again, if there's an issue where maybe there's too much acetylcholine activity and you're not allowed for full relaxation, you can see how the bladder may be less distensible and less able to fill with urine to an appropriate volume. And so, of course, this is a very coordinated effort between organs, so you need to know that you have to have good neural connection between the brain down to the spinal cord and to the pelvic nerves. If you had, again, someone with a spinal cord injury, this may be a potential side effect there where you kind of lose that connection and they may not be continent anymore. So a few different types of incontinence or stress urinary incontinence. This is usually related back to urethral underactivity. Okay, so this is going to be things like brief bursts of activity, like exercise, or if they sneezed or coughed or something like that, where a brief burst of activity will cause that sphincter to basically give out for just a moment, and you have a small amount of leakage that can occur there. And again, usually due to decreased or inadequate closure forces there, usually episodic, usually low urinary volume for the most part. Obviously, risk factors include things like pregnancy and childbirth. Things like menopause, obesity, aging can all increase your risk for having this sort of stress urinary incontinence. Pretty rare in men, but could be causing things like surgery. If you imagine like a patient getting a prostatectomy or something like that, could be seen. And then this can be aggravated by certain medications. So an alpha antagonist, as we saw, is going to be a smooth muscle relaxer. This can potentially relax that urethral sphincter, right? So that could be one thing that can cause an issue there. And then ACE inhibitors, we know that causes cough as a potential side effect. Less likely with the ARBs, but certainly causing that dry cough can certainly cause some stress urinary incontinence there. And then there's urge urinary incontinence. So again, the stress, usually related to kind of big increases in pressure for a short period of time. There's urge urinary incontinence, which is typically due to bladder overactivity. So again, this is going to be related back to urgency, that desire to void. You're going to find that the detrusor muscle is overactive and may have involuntary contractions. And we said the primary thing that causes that to constrict is what? Which is neurotransmitter? Acetylcholine, right? Acetylcholine is muscarinic receptors. So again, you're already starting to see what medications may be good for this, what type of drugs we're going to be looking at. Again, this is not overactive bladder. This is not necessarily frequency. It's more related back to the urgency. It could be idiopathic in a lot of cases, or it could be related to some neurogenic overactivities to things like aging, neurologic disease, or if you have like a bladder outlet obstruction, that could be another issue there. And certainly can be worsened by things like diuretics and alcohol. Why do you think alcohol affects this? Huh? No, not really muscle relaxer. I'm sure none of you guys know about this because you guys are good kids and you guys don't go out drinking ever. But you ever heard of the term breaking the seal? Remember we mentioned this. Remember, like once you go to the bathroom once after you've been had a couple of beers, all of a sudden you have to go to the bathroom all the time. Remember, what does alcohol do to ADH? Antidiuretic hormone. Depresses it, right? Depresses antidiuretic hormone. So less antidiuretic hormone, we have more diuresis, right? So we get more bladder activity. So again, these are things you can think about how this can be all factoring into the pathogenesis of these kind of issues here, right? So then there's also overflow incontinence. This is usually due to urethral overactivity. So the urethra is too active and then the bladder's underactive. So basically you're holding on to it too much. Imagine like a water balloon, you're pinching off the end of it and it just keeps getting bigger and bigger and bigger. And you can't ever have any outflow. Eventually it pops, right? You don't want that to happen to your patient. So we're going to try to prevent this overflow incontinence here. But basically, you're going to have leakage due to the fact that the bladder is very filled and is really unable to empty. And this is usually due to kind of chronic urinary retention, right? So this could be related back to medications, could be related back to some other things as well. But mainly urethral hyperactivity, mainly going to be seen with things like BPH in guys, and it also can happen with certain neurologic conditions like spinal cord injury and multiple sclerosis. You can have bladder underactivity though, and this is where the bladder is basically unable to completely empty. You're going to have some leftover residual after every urination. And so this could be related back to things like diabetes, where you have some neurologic damage being done to those nerves there, or due to kind of long-term bladder outlet obstruction. And so we can find certain drugs will cause this. So medications that will cause urethral hyperactivity include things like alpha agonists and also tricyclic antidepressants. We'll talk more about that later when we get to the psych section. And then drugs that are going to decrease bladder contractility are going to be mainly anticholinergic. So think about things like Benadryl. Think about a lot of the drugs we're going to talk about here in just a few minutes that are anticholinergic that can cause this. But also things you may not think about like antipsychotics, calcium channel blockers can all do this as well. So again, you'll find that the presentation is going to differ depending on what type of urinary incontinence they have. So again, urethral underactivity is going to be seen. You'll see leakage with physical exertion. So again, this kind of goes back to their history and presentation. Bladder overactivity is usually going to be related back to urinary frequency. So again, more than 8 times a day, having a lot of urgency associated with that. And then overflow incontinence, usually going to be related back to things like lower abdominal fullness, hesitancy, incomplete bladder emptying, and it may have frequency and urgency associated with that. And so again, the treatment is going to differ based on what kind of the main pathological issue is here. So I mentioned course of therapy depends on what is really bothersome to the patient. Is it the volume of urine that they're having issues with? Is it the frequency? Are they using things like absorbent pads? Are they going through them very frequently? Is it kind of being a problem? Because again, this is a lot of it tends to be a quality of life issue for a lot of patients. So again, you have to kind of assess kind of what's the main problem for them. So our goal obviously is restore continence. We like to reduce the number of episodes of incontinence and then prevent any kind of complications, especially with our older patients, things like nursing home placement and whatnot. Oftentimes it's kind of one of the cutoff points where people just can't really care for a patient anymore, as there's really, really bad incontinence in a lot of cases. And again, we like to minimize adverse effects, minimize costs, and then try to increase their quality of life if possible. So generally, you're going to find that drugs are going to be for patients with who are not controlled with non-pharmacologic therapy alone. So again, you're going to find that we try non-pharmacologic stuff first. We'll talk about that in a second. And then we'll move on to drug therapy here. And then you can use multiple therapies. You can use non-pharmacologic plus pharmacologic therapies in conjunction. And then the drug selection is really based on that urinary incontinence type we were kind of alluding to previously. And then always consider comorbidities as well. So non-pharmacologic therapy, better for mild to moderate symptoms. These are good for patients who want to avoid drugs potentially or avoid surgery. And it goes back to a lot of like behavioral interventions. So things like if they know certain activities kind of exacerbate it, they can avoid certain situations. They can all be very useful. Usually a lot of lifestyle modifications like toilet scheduling regimens, things like that. Some patients may benefit from things like pelvic floor rehabilitations, like doing their Kegels and whatnot. And then again, if they are older patients, have caregivers, they need to be really active participants here as well. Right? But we like drugs, so we're going to focus on drugs. And so you're going to find that for urge urinary incontinence, you're going to find that anticholinergics are going to be our first line. So again, as we mentioned, that for certain types of urinary incontinence, especially the overflow, we're going to find that anticholinergic can cause that. Here, for this urge urinary incontinence, we're actually going to be giving anticholinergic. This will help to relax that detrusor muscle, will offer more filling of the bladder in order to get the patient more time to where they can actually go and micturate when they want to. And so we have several drugs. You're going to find these have varying levels of affinity specifically for working on the bladder. So things like oxybutynin or ditropan, tolterodine or Detrol. These are probably two of the most common ones I see being used. We also have things like trospium, solifenacin, darafenacin, and fesoterodine. Again, probably these top two are the ones I see most frequently. And so these, again, are going to be antagonizing those muscarinic receptors and suppress that kind of premature detrusor contraction, right? So they allow for better storage of that bladder by keeping that muscle from really contracting there, okay? These are all considered equally effective. Biggest choice is going to be how often you have to give it, how much does it cost, and what kind of side effects the patient get from it. So usually you're going to find that a lot of them have long-acting formulations. So these are good for, if you see like LA or XL, those are going to be good formulations because you only have to take them one time a day, which is nice. There's also some transdermal preparations as well. Like, who might that be good for? You like your older patient, like, again, if it's a caregiver administering, they just slap it on. They don't have to worry about it for a few days. They'll be able to keep it on a regimen. That's usually the patients I see doing a little bit better with that. Again, looking at the adverse reactions. So we mentioned that when you have too much cholinergic activity, you get those dumbbells, right? So the defecation, urination, meiosis, all that stuff. Anyone remember the mnemonic we use for anticholinergic side effects?
Dry as a bone thing.
Dry as a bone. Good. So you can see like urinary retention, which is kind of what we're trying to cause here, right? What else can you see? Mad as a hatter, right? So there could be some CNS side effects. So there's sedation being a big one. Hot as Hades, so you get very flushed and you can see hyperthermia. You can see constipation. Red as a beet, so you get very flush. Blind as a bat, yeah, that's the other one, right? So you get mydriasis, that can be another one. You have impaired accommodation, right? So again, think about those side effects as kind of being the most common one. What do you think it does to the heart rate? Increase it, decrease it? Speeds it up, right? Because again, think about normally acetylcholine on the muscarinic receptors in the heart slows it down, right? So think about something like atropine reverses that and will cause heart rate to go up, right? Good. So again, if they already have urinary retention, you probably don't want to give any of these because that'll just worsen it. They have impaired GI motility. That could also be a problem because, as you mentioned, constipation is one thing, but slow GI motility can be an issue with these drugs as well. Uncontrolled narrow angle glaucoma. This can worsen that, so you don't want to do that. And then myasthenia gravis. So have you guys covered myasthenia gravis? Probably cover it in the neuro section. Basically, it's an issue with impaired activity of acetylcholine at the neuromuscular end plate. Again, we're just going to avoid it for those patients, but it's pretty rare this comes up normally. Again, due to those Mad as a Hatter effects, you can see mental status changes in the elderly, so falls are going to be a risk here as well, so you can always keep that in mind. And you don't know, is it grandma getting more demented? Is there her mental status going, or is it the medications we're giving her? So that's always a consideration you have to consider there. Now, one of the biggest side effects you're going to see most often is probably going to be dry mouth. So I mentioned it dries things out pretty seriously. So again, anyone know the special scientific name for that? Xerostomia. So if you ever see that, it's another kind of fancy name to impress your friends for dry mouth. But anyway, again, looking at things like oxybutynin, one thing to note here has risk for orthostatic hypotension. There's a little bit of alpha blockade with it seen, which can be an issue if you have patients who are kind of frail from the cardiovascular standpoint or have a lot of other medications for hypertension. The big thing to note, especially with these XL formulations, you do not want to crush or chew them because they will kind of release all the drug at one time. You can see a lot of anticholinergic effects all at once, right? So you don't want to do that. You want to make sure they're intact. And so this is why, some patients cannot really tolerate the oral medications. If they had a stroke or something like that, it kind of precludes that. Something like a patch can be very useful from that standpoint. Now, and oxybutynin XL is probably going to be recommended first line in a lot of cases just due to low cost and low adverse effects from that standpoint. Tolterodine, do you want to watch out if they have really poor creatinine clearance because you can see decreased clearance of the drug from that standpoint. And then if they have another CYP3A4 inhibitor on board, reduce the dose because it actually gets metabolized by that. So it's one interaction to worry about. So again, as far as the other agents, trospium, again, this one is nice because it's a second generation anticholinergic. It actually is a structure, the quaternary ammonium, which basically just means it has a positive charge on it all the time. It means it can't cross the blood-brain barrier. So you limit a lot of those CNS side effects. It might be better for patients who are more prone to see issues like that, right? So they get a little loopy when on those, oxybutynin or something. Trospium might be a better option for them because it really won't cross that blood-brain barrier. Other things you could do, botulinum toxin. Anyone know what you use botulinum toxin for? Use it for Botox. What do you use that for? Yep, you can use it on the facial muscles to make people look younger and very surprised for longer. What else can you use it for? Yeah, so migraine. So especially if you have really tense muscles kind of in the back of the neck, you can have some injections there to kind of loosen those up. What else can we use it for? Yeah, sometimes for sweating, actually paralyze some of those sweat glands. We will sometimes use it for kids with like cerebral palsy and other kind of spastic conditions. We'll actually inject that into some of their larger muscle groups to try to release some of that spasming. Basically, this is one of the deadliest, actually most potent toxins known to man. I think something like on the order of micrograms of this stuff can kill the entire room here for sure. But very, very deadly stuff. And so it's I always thought it's funny how we do anything for beauty, right? And we inject this really deadly poison into ourselves to look a little bit younger. But anyway. There are some good medical uses for it as well. Again, and I'd always be cautious. I always see this road sign like on the side of the road. It says like, "Oh, Botox, $10 a unit." I was like, "Oh, I don't want Botox from this guy. I don't know where they're getting it from, but no thanks." Anyway, it's very good though. It's a very good neurotoxin that paralyzes smooth and striatum muscle. Right? Anyone know what foods you can find this in? Yeah, so like improperly canned food, you can actually find some risk for Botox. I'm sorry, for botulinum toxin. Anything else? What don't you give kids less than a year old? Yeah, honey. You can't give them honey because there is botulinum spores that can actually germinate in the young GI tract. So we don't want to avoid honey for those young kids. But anywho, just a little bit of trivia. So this actually prevents release of acetylcholine. So if you prevent release of acetylcholine, then it can't really work at those muscarinic receptors because it's being held back in the neuron. And so this is used sometimes off-label for refractory urge urinary incontinence. So again, if it's more of a neurogenic issue, the anticholinergics are not working super well, you can use this as a kind of an off-label use for these drugs. And you can actually inject it directly into the detrusor muscle or into the bladder itself, and you can actually find pretty good duration of action here, anywhere between 4 to 8 months. But as you might imagine, you can see some issues with this, namely urinary retention being the worst side effect associated with it. Otherwise, other than that, it's pretty well tolerated for the most part. But again, more invasive, probably want to hold off on that unless your other medications have failed. If you have urethral underactivity, this is going to be, our therapy is going to be aimed at things that actually increase urethral closure. So this is something where estrogens can be very effective here. They're actually thought to encourage kind of growing of this urethral epithelium. They're thought to help with local circulation and also increase the number of adrenergic receptors that are available at that site. So again, more receptors available, more likely they can be affected by the natural norepi and things like that your body's releasing anyway. And so you can use this a lot of times in like postmenopausal women, especially. This is where they can get things like transdermal estradiol, conjugated estrogen. We'll talk a lot more about these when we get to kind of the women's health section next semester. Again, just know that there is some questionable efficacy. Probably these are the best drugs we have for. We don't really know anything else that works especially well for helping with that urethral closure. However, we use primarily the transdermal forms for a lot of urge urinary incontinence. So again, just consider that. Again, we'll talk more about that later on in next semester. Other things we can do, we could use alpha receptor agonists. So again, imagine if we had an alpha blocker that could cause the urethral sphincter to be too relaxed. We actually end up closing it with some of these other drugs. We used to use a drug called phenylpropanolamine, but this actually got removed from the market due to stroke risk. Too much adrenergic side effects, essentially. Blood pressure went way too high, caused people to stroke out. So that wasn't good. But we can actually use instead is a drug called duloxetine or Cymbalta. Anyone know what we normally use this for? Never heard of the drug Cymbalta before? Yeah, usually used for depression or sometimes for neuropathic pain. So again, this is another off-label use, but basically it helps to block reuptake of norepinephrine. Basically, helps to increase amounts of norepinephrine available at the synapse, and can actually increase that urethral closure. Again, probably not a lot of evidence to support use. It actually got approved in Europe though for stress urinary incontinence. But again, might be something you see used occasionally. We'll talk again more about this drug when we get to the psych section next semester. I'm just trying to like give you guys a lot of like coming attractions, so you guys are really, really jazzed up about coming back next semester. Like I'm just gonna not take that course. It's terrible. Anyway, going back to the overflow incontinence, we talked about a lot of medications. Again, a lot of overflow incontinence goes back to kind of bladder outlet obstruction. So again, most of the time that's BPH. Kind of review back on that section to see the meds we can use for that. Okay. So, any questions on this section? This is the end of material. If you guys have questions, I will entertain this until you all leave the room, essentially, for the test. So we covered GI, we covered renal, urology. What else did we cover? Was that it? GI and urology, that was it? Man, you guys got off light. I guess that helps me put all the cardio in one section, right? That helps me put all the cardio in one section. This one's pretty light. In regards to that. Okay, so any questions about like maybe ulcerative colitis, Crohn's disease, GERD, H. pylori? Yes?
What would you tell us is a commonly missed concept on a test? Or
I cut out a lot of the stuff that was actually commonly missed.
Thank you.
I tried to skinny up the lectures this time around a little bit. A lot of stuff like hyponatremia, and things like that. I didn't want to get too in depth on for you guys. Again, you guys would probably be thanking me if you saw the slides.
Thank you.
Yeah, no problem.
The target cell.
Yeah. Anyway, probably the biggest things. Just know, like, what your patient's presenting with, be able to, like, kind of evaluate the question and see, like, okay, what is the primary problem we're trying to address here, right? Is it medication induced? Is it disease state induced? What can we use to fix that issue? Just really look specifically at kind of what we're looking to treat there as far as that goes. So again, specifically, if you were looking at, nausea, vomiting induced from, I think, a good reason. Like we talked about, things being used for like chemotherapy-induced nausea and vomiting. Like again, those treatments, we saw things like aprepitant, like the substance P antagonists. We saw things like corticosteroids, like dexamethasone, being used for that, as opposed to just routine, everyday, normal nausea, vomiting. You can use things like Zofran. You can use things like antimuscarinics, like Phenergan or metoclopramide, things like that. So just kind of keep that in mind. Keep in mind where each of the drugs should be used. I think this will be kind of a different test for you guys than last year, so I'm not really sure what the stumbling blocks will be this time around, but. I don't know, we'll see. Dr. Levine has already reviewed it, and I only had grammatical updates to make, so I got her seal of approval. It was good. She was, I worked with her over at Nemours briefly when she was a pediatric intensivist over there, and she was always very intimidating to deal with in some cases. You never thought such a little lady would be so intimidating, but call her about something, be like, this looks a little crazy. Are you sure you want to do this? And she was like, I've been doing this for 30 years. And okay, I'm just going to let you do that. Sounds good. Very informative. Okay, well, if you have any questions, the test is next Wednesday, right?
Thursday.
Oh, Thursday? I won't be here for it. I won't be here for it. You guys double check with your campus. I will not be here. No, I will not be here for that one. I will be here with you in spirit. So if you feel that ghostly presence over your shoulder, may or may not be me. Otherwise, I'll see you guys next semester.